But what if you just test everybody with cancer? This is a study from Sloan Kettering where they basically did germline and tumor sequencing on everybody who came in the door. And when you look at this, you can see that 16% of people with almost all these common cancers had a pathogenic variant that was actionable. And 74% of these individuals would not have met a guideline for getting testing, certainly not before they were diagnosed with cancer. So this is an important lesson that when we start moving toward population-based approaches is where we get to prevention.
The International Society of Oncology Prevention and Treatment, or ISOPT, believes every adult deserves to know their cancer risk before cancer arrives.
It's a great honor to be here. I want to thank Professor Lau, Dr. Balch, and also our collaborations, East and West. So working with Dr. Lau and Dr. Wu, who just presented, and with Dr. Balch, we're really global. This is a global issue. So genetics isn't limited to one global community or another. It's all global communities. Today, I'm going to talk a bit about the observations and that led us to understand genetics and cancer, some of the tools and the advances in those tools, the training that we can use to harness to get to use those tools well, and then the compelling evidence why we should do what we're doing. And I'll talk about alternative approaches for more efficiency to expand our reach, an implementation term, and then how do we triage complexity to expertise? So first off, when I look at things, I know this is hard to read the small print, but this is really encapsulating the history. Because when you think about it, 1971 was when Henry Lynch first made observations about Lynch syndrome, hereditary colon cancer, uterine cancer, and ovarian cancer. It took quite a number of years, but in the 1990s, we were able to identify the genes responsible for Lynch syndrome, for hereditary breast and ovarian cancer, for Lee-Fermani syndrome, which is P53. And all of this was when we were using technologies that were extraordinarily expensive and painstaking. We call it the positional cloning era. It wasn't until 2000 that we had the first blueprint for the genome that we now take for granted as a blueprint that we can explore. In the next decades that followed, the thing I'm most impressed with and most proud of is that we established the evidence for the advice that we provide, learning how to take care of patients with high risk, and then showing that if they do the right things, that they will live longer and have less cancer. In the mid-2010 to 2020 era, we shifted into next generation sequencing, more efficient, cheaper, and allowing us to expand our reach globally. We started going from testing one or two genes based solely on the phenotype to multiple genes based on the fact that they had cancer or that they're just a member of the general population. And then we moved really more quickly into whole genome sequencing. So not just the genes that we're interested in, but the entirety of the genome. And that gave us access to other genomic risk signals, which I'll summarize as polygenic risk later in my talk. So I'm really excited about the fact that we're at the era now, as illustrated by Dr. Lau earlier when thinking about somatic testing for tumors. This is all based on genetic technology, and whether you're sequencing a tumor or the germline, we're really talking about the same science. How common are they? So pathogenic variants, abnormal versions of these genes, are evident in at least 10% of breast cancer patients, 25% of ovarian cancer patients, and in fact, it turns out that prostate cancer has the highest genetic burden when you look at twin studies, but it's very much polygenic, but we still find 10% among prostate cancer patients. So focusing now on breast cancer, we started with BRCA1, breast cancer gene 1, and breast cancer gene 2. They have the most extraordinary amount of work, and they still are responsible for the greatest burden of hereditary breast cancer and ovarian cancer globally. But we also know about the other genes like P10, which is Cowden syndrome, P53, which is Lee-Fermani syndrome, and then the non-syndromic genes, ATM, PALB2, CHEK2. And then I'll touch briefly on polygenic risk. So this is the idea that I mentioned, which is that we have evidence for each stage of this. So why is it compelling for us to recognize these patients and to learn how to take care of them? First off is if you find an abnormality in BRCA1 or 2, or one of the high penetrance genes, we can test the adult relatives. There's also more exotic technology to test embryos, but I'll stick to the adults for the moment. We have evidence for advice. If you remove the ovaries as a preventive maneuver, you have the highest level of evidence, all-cause mortality reduction. That makes it truly compelling for us to identify the individuals who warrant those interventions. We have targeted therapies. So thinking about Lynparza and AstraZeneca's drugs that relate to PARP inhibitors, this was a signal, one of the earliest targeted therapies in the precision medicine era. We have evidence that if you increase surveillance for individuals with hereditary breast and ovarian cancer, that you reduce mortality and that we effectively downstage, that we go from stage 2 or 3 to stage 0 to 1. And this is evidence, prospective evidence, and a prospective evidence for reduced mortality. And underutilized, but still potentially important, are chemoprevention approaches. Now, reflecting on Dr. Nant's comments for the St. Gallen's consensus, almost all breast cancer. So we aren't, the NCCN guideline, and I was on the committee for 19 years, are Byzantine, to be honest. But we can simplify it. For over a decade, all ovarian cancer, all pancreatic cancer, all metastatic prostate cancer, and then all triple negative breast cancer. So we're really getting to all breast cancer. The only group that is not included currently are HER2 positive over 65, basically. That's about it. So for the most part, we simplify the guideline to test all individuals with breast cancer. But we don't treat them all the same if we find a variant. So for an unaffected woman who's 35, this is an important counseling point. Her risk over her lifetime, we look at 60% by the age of 85 in this graph on the left. And on the right is the same exact variant, but in a 60-year-old woman who I'm seeing for the first time, just found out she's a carrier. Her lifetime risk is different because she's postmenopausal. And so one of the art of counseling for cancer risk and management is that we don't treat them all the same. The woman who is 35 right now is facing 50 MRIs over her lifetime. Her decision to choose a risk reduction mastectomy is presumably much more effective and appropriate than a woman who's 60 who faces only 20% chance of getting breast cancer in their remaining lifetime risk. So we treat them differently. It's important. Turns out, though, that the ovarian cancer management is ageless because most of that risk, even early onset, is 60. Most women get ovarian cancer in their 70s. So there's substantial and actionable ovarian cancer risk at any age with a BRCA pathogenic variant. And that's important to recognize. Pretty much, I would say that there is no upper age limit when I wouldn't remove the tubes and ovaries as prevention. If it's a woman who I would take to surgery, remove the tubes and ovaries and debulk her for ovarian cancer, and then give her chemotherapy, it's much easier to do a same-day procedure and remove the risk entirely. So there's really not an upper age limit, but it is important. And it turns out that the ovary is probably the most important part of management. Now, what if you find these genes and you weren't looking for them? In other words, population-based approaches. This was alluded to earlier, but this is one of the groups called the Carrier Study that looks at all the legacy cohorts in the US, Nurses Health Study, the Women's Health Initiative, sequenced all of those individuals. So now we know that if you find a BRCA1, you can see that the risk in the middle panel is only just over 50%. But this is a cohort that was identified later, not based on their history per se. It also showed us that ATM, for example, was barely actionable, just meets twice the risk of an average woman. And so we don't treat each of the genes the same either. We also learned that there were certain genes that we thought were associated based on vendor-based studies, that is genetic testing companies, that they really weren't. The Lynch syndrome genes, NBN, they were essentially demoted with regard to actionability for breast cancer risk. However, they are important for ovarian cancer risk. So if you look at this, the top ovarian cancer genes are still BRCA1 and 2. But next are the Lynch syndrome genes, clearly actionable for ovarian cancer risk. And then the ovarian cancer specific genes RAD51C, RAD51D, and BRIP1. And finally, you get to PALB2, which is right at the threshold of when to consider risk reduction salpingo-oophorectomy. And that orange bar across the middle is essentially the risk if you have a close relative with ovarian cancer. And why do we consider that actionable? Because we can't screen effectively for it. So it's much easier to prevent than to treat. So I think of multi-gene panels in a way of what is the phenotype? What am I trying to explain? If it's breast cancer and pancreatic cancer, as you see on the left, ATM, PALB2, BRCA2 are the most important genes. If it's melanoma and pancreatic cancer in the family, CDKN2A. If it's breast cancer and prostate, we think of BRCA2. If we think uterine and breast cancer, PTEN and Cowden syndrome. So it's a way of thinking about what is it I see in front of me, which means family history is still important. But what if you just test everybody with cancer? And so this is a study from Sloan Kettering where they basically did germline and tumor sequencing on everybody who came in the door. And when you look at this, you can see that 16% of people with almost all these common cancers had a pathogenic variant that was actionable. Now, about half of those were likely causal for the cancer in front of you, but the other half were important because they were risk for new primary tumors for the individual, but important because they were a risk for cancer in the family. And 74% of these individuals would not have met a guideline for getting testing, certainly not before they were diagnosed with cancer. So this is an important lesson that family history is important, the criteria are important, but when we start moving toward population-based approaches is where we get to prevention. So some of the genes are associated with the well-known syndrome. We know a lot about BRCA1 and 2. We know what they do and don't do. We know what it means for family members. It is clearly actionable. And if they don't have the variant in cascade testing, they are actually given a pass. But for the moderate risk genes, it gets complicated. It's nuanced. We know about a few of the cancer risks and others aren't so clear. We also know that the implications for family members are nuanced. But now let's think about the whole genome. On the left are the monogenic risks, so the high-risk genes, each of them with a big effect, but relatively rare. We talk about 1 in 10. On the other side are the polygenic risks. They're very common, but each of them alone has a very small risk. The two together are what's most potent. So this is for polygenic risk, taking all the SNPs. But what I want to highlight is that in the middle on the graph on the left, where it shows the figures, you can see that most people are right in the middle, that a few people are at the extreme to the left, which means their risk for breast cancer is probably less than 5%. And there's a few people at the extreme right, which some of those people are going to be at 30% risk. Note that none of them are over 50%, and that's not surgical. But the point is we can now start to be more precise and stratify the risk according to the groups. So these are being implemented. One of the early criticisms was that it wasn't ancestrally anchored. Well, it is now. You can correct, seen in the top left panel, where you take these disparate curves, you can now use principal components of ancestry and you can align them so at least it's accurate. And you can integrate these in a empiric risk model, in this case, the Tyrer-Cuzick model, which incorporates risk factors plus polygenic risk score, and it improves the area under the curve, so the predictability. So these tools are getting to be ready for prime time. And you can also apply the polygenic risk to the genes themselves. So somebody with a BRCA1 gene mutation and a polygenic risk score that happens to be low, they actually move lower on the scale. And the same moving higher. It explains why some of our PALB2 families don't look very serious and others look very serious. You start to spread the risk and get more precise about where does somebody live on that curve. So these are several examples of this. Now, implementation of polygenic risk scores. You will hear in the ISOPT meeting from Dr. Laura Esserman, and she's the principal investigator of the Wisdom trial. So this is the first clinical implementation, 28,000 women, and they showed that risk-based breast cancer screening, more screening with more risk, less screening with less risk, improved diagnosis of under stage 2 breast cancers. So that's a rough estimate that it was non-inferior to doing it another way, but it was the first implementation study. Further, they were testing germline variants too. And just like the other studies I've already highlighted, many of the individuals who had a pathogenic variant, which guided their care by guideline later, would not have been identified if you followed the family history guidelines strictly. And finally, they showed that you could change behavior if you implement this. So reduction in alcohol use, increase in exercise. So risk assessment and counseling makes a difference. Now, well, how are we doing with regard to germline testing in the United States? I mean, we've been doing it for 20 years. Well, not so good. Alison Kurian, one of my most esteemed colleagues, has taken and looked at the SEER data, the population-based data, triangulated that with the genetic testing vendor data, and we can see that on this graph, ovarian cancer, we've been supposedly testing all ovarian cancer patients for germline for a decade. We're under 50% nationally. So we're not passing muster. We're not doing a good enough job. Why? We need more people who are trained and more people knowledgeable about implementing this. And we need to de-exceptionalize genetics so that it becomes more a key part of care. How do you get there? Well, training is one way. I started a course at the City of Hope where I spent 24 years, where we're doing a virtual model of training with over 100 hours of training, and most of it is done virtually. Any of you can take this course. We train oncologists, geneticists. We train the geneticists in oncology, the oncologists in genetics. We train advanced practice nurses and others to help us with this journey. After you get through the training, you become part of a community of practice. Now, Dr. Balch showed you earlier the tumor board and Dr. Lau that they do every month here, a broadcast throughout China. Well, we do a tumor board on genetics, and you can vet your cases and be part of the community of practice. Well, this is my colleague, Dr. Kathleen Blazer, who continues to lead the course. We have a global impact with over 2,500 people trained, every state in the United States and 27 countries. You can see we don't have enough flags yet in China. We have many in other countries. And our newest graduate is Dr. Charles Balch. So Charles can do it. Well, I wouldn't say you can do it. Charles is extraordinary, but you can do it. And so Charles took the time to do the course, and I'm so proud of him. He's now a certified cancer risk consultant. Now, how can we do more efficient approaches? This is called the Magenta trial, which was looked at, well, do you have to counsel everybody before you test them? And the answer is no. You can test them and then counsel those who had an abnormal result or a complex history that needed explanation. So this is called the Magenta trial, and it's called for post-test counseling. One way of doing this in a better way, how do we expand reach? Why is this important? Because first off, oncologists and oncology surgeons are where they need to be, in the cancer center. Their focused cancer genomic professional education can help them do the right thing. And the trials are showing us that we can do it in different ways. So how do we identify the most important group? 30 to 60-year-olds. First off, family history is still important. Genetic testing, focus panel versus a whole genome. Summary risk and management ideas are important for this. And then we have to make sure that they actually get the surveillance. And then most importantly, that we facilitate cascade testing for family members. Mainstreaming is a concept that's been brought about. You still do counseling, but anybody can order the testing through the electronic medical record. And the bottom of this slide summarizes a study where they did an EMR embedded clinical decision pathway that they showed, and this was at Kaiser Permanente, and they showed that they increased the number of people who got tested, that it was satisfactory, and that they worked out all of the kinks in how to do this. What's important to recognize, however, that was emphasized here is that mind the dependency. It works when clinical genetic counseling support is available for the positive and complex results, and that mainstreaming should be a way to strengthen genetics, not reduce it. So this is a pedigree. This is a family who I took care of. The woman on the left in the bottom with breast cancer at 40 was negative for BRCA. We tested her with a multi-gene panel and she had PALB2. Great, we have an answer. However, we can't tell which side of the family it came from. Mom is unaffected, but there's breast cancer on her side of the family. Dad didn't have any sisters. How are you going to see breast and ovarian cancer if he has no sisters? But his brother had pancreatic cancer. Turns out that pancreatic cancer is part of PALB2. So this is an example of a complex history that you would need to do the cascade testing. This woman's brother has a 50% chance of being a carrier. And then look, he's got daughters and a son. Cascade testing is essential to expand our reach through these. And the moderate genes we're learning an awful lot about. So for patients with complex histories, we need to do multi-gene panels. I think of whole genome and whole exome sequencing as the next generation sequencing. It's now economically viable. It never was before, but it is now. PRS holds the promise of further precision. We now have at least one implementation study that has been published. I think we're now at an inflection point in using this tool for improving our care, and you'll hear more from Dr. Esterman later. Tumor and germline testing together in precision medicine makes perfect sense. When you're looking at the tumor, you're looking at the germline with a few added features. So I just want to highlight that I'm honored to be here, that genetics education is essential, but that we can all do this together. Thank you very much.